Hello, this is an EKG case review for a 31-year-old male with general weakness. And you respond to this patient that's got generalized weakness. He's unable to stand. He's got extreme difficulty coordination, but he's alert and oriented. And his mom decided to call you after she started noticing that these symptoms were occurring, and she lets you know that he missed the medical appointment today. The patient is pale and diaphoretic without any signs of trauma, and he's very lethargic and starts to become even more confused the longer you talk to him. So before we start looking at the 12-lead EKG, let's talk about what are some of the additional assessments we might do or questions we might have. Of course, we want to get a full set of vitals on this patient to they're presenting like somebody that's got poor perfusion with the pallor and the diaphoresis. We're going to want to get a blood pressure, get a good pulse, see if they have a pulse dystole, and even potentially start a line and start working this patient up. We don't jump right into getting a 12-lead EKG. We're going to want to ask further questions, get more patient history. And as you're doing that, you have, your partners and your crew work on getting you your 12-lead EKG. So let's start to take a look at this 12-lead EKG. I included the measurements off to the left here. So you've got a heart rate of 67 beats per minute. Let's assume that's accurate. A PR interval of 64 milliseconds. And what I believe that the monitor is calling P waves are right about there. They are very low voltage, but for the sake of argument, let's just say that those are P waves for this EKG. QRS duration, it's saying is 208 milliseconds. If you're not familiar with milliseconds, that's like saying 0.208 seconds. So a normal QRS duration should be less than 0.12 seconds, which is 120 milliseconds. So this is very wide, right? And if you're having a difficult time identifying where the QRS begins and ends on this EKG, I can give you like a quick little how-to when you are able to identify certain things. Like if you were to look at lead 1, for example, it's difficult to see where the QRS begins and ends, right? But look at AVL, okay? AVL, the QRS clearly begins right about here and ends right about there. And then you have a T wave right there. So what you would do is first understand that this beat above that beat is the same beat as this beat, and that's the same beat as this beat. It's just taken from a different angle of view, right? Each lead is a different camera angle of the same beats, right? So all three of these beats occur at the same time. So if the QRS starts here, on that EKG, or on that lead, I know it's going to be starting right about there in that lead. And if it ends here, then it's going to end right about there in that lead. So this measurement of 208 milliseconds is accurate. Then we see the QT or the QTC interval. We always look at the QTC because that's been corrected for the patient's heart rate. A different heart rate might have a different normal QT interval. So the QT interval should be about 400 milliseconds up to about 500 milliseconds. In this case, it's a little bit short, 338 milliseconds. It's profoundly short, but we're going to go further in our interpretation of our 12-lead EKG to determine what might be causing that. And then we have our cardiac axis. We typically look at that middle one, which is the QRS axis of -40. That would be a left axis deviation. And this, does fit a left axis deviation. There are many different causes of left axis deviation, like a fascicular block, left anterior fascicular block specifically, left bundle branch block can cause it, different types of dysrhythmias like a ventricular dysrhythmia, so on and so forth. Let's interpret this 12-lead EKG further. So if these are P waves, then we would have a sinus rhythm, okay? But what we notice is that the QRS duration, or the width of that QRS complex, is profoundly wide. It's very wide. So you have a differential for a supraventricular rhythm with a wide QRS. And the first thing on there is going to be an interventricular conduction delay, right? A bundle branch block. That's the fancy way of saying bundle branch block. So either a left or a right bundle branch block. In this case, it would be a right bundle branch block pattern if that were what was going on with this patient. However, this is a very wide QRS, and it's starting to look, abnormal. Whenever you see a straight line from the nadir of the S wave, look at lead V3, to the peak of the T wave. If you see a straight line there, that's highly concerning and really, pathognomonic of a certain condition that we're going to talk about here in a second. So the first differential for a supraventricular rhythm with a wide QRS complex is intraventricular conduction delay, or a bundle branch block. The next one would be electrolyte derangement, like hyperkalemia, right? And then the third one would be toxicity, like a tricyclic antidepressant overdose. So luckily with those two, you really have a good source of information in this case, because every 12 EKG comes with a patient. So let's get a good patient history, right? Let's ask some questions. So going back to that patient, what was the medical appointment they missed and what kind of medical history do they have? And the mother tells you, this patient has end-stage renal failure and they missed their dialysis. Well, that should be like a red flag, because if we're thinking tricyclic antidepressant overdose, you would, they have some sort of depression and they missed, their appointment with a psychologist or a psychiatrist. Or if you're thinking something cardiac, well, it's a 31-year-old male. It doesn't really fit that unless there's significant cardiac history. So you got to get the history, because every patient or every 12 lead comes with a patient. And in this case, it's a renal failure patient. And that means they're at very high risk of hyperkalemia. And that's what this 12 lead EKG is showing us. So that straight line that I told you about from the tip of the nadir of the S wave to the top of the T wave can help or cause a pattern known as a sine wave pattern, which we're going to talk about in a second. This patient is severely hyperkalemic. They started losing mentation and eventually went into it and deteriorated even to an even worse condition. The 12-lead monitor itself did not identify hyperkalemia, and it never will. It identified STEMI. It probably was seeing, this as ST depression and seeing, something like this up here as elevation. Okay, so it was identifying a STEMI. It did identify, of course, the short QT interval, and its measurements, usually the measurements are accurate. Often the diagnostics are inaccurate. So no matter what the diagnostics say, we're going to have to confirm it as a clinician, as a provider, okay? So in this case, the patient is hyperkalemic and had a serum potassium level of 8.6, which is extremely high, severely high, and lethal. So let's talk about some EKG changes with hyperkalemia. We're talking about sine wave or close to what's going to become a sine wave pattern. A sine wave pattern comes from, like if you ever took trigonometry and had a graphing calculator and put sine in as your y-axis and hit enter, you would see a sine wave. Remember sine, cosine, tangent? The sine wave is simply a straight line up and then down and then up and then down without a lot of breaks in it. And you can see it on a 12 EKG of a severely hyperkalemic patient. And when I say severely hyperkalemic, this patient is about to die. If they are not emergently treated, if that serum potassium level is not emergently corrected, they will go into cardiac arrest and die. And it's going to be a difficult arrest to work. There are treatments, of course, for hyperkalemia. This patient did not receive their regular treatment of dialysis, which would have lowered their serum potassium level. And I'm saying serum potassium level specifically because that's where the potassium level is high. So the treatment often involves shifting the potassium into the cells. That's part of the emergent treatment that they will receive. Pre-hospitally, there's not a lot that's done. Traditionally in the past, calcium chloride has been administered pre-hospitally. However, it's difficult to definitively diagnose a hyperkalemic patient pre-hospitally, and giving empiric calcium to patients who assume are hyperkalemic isn't necessarily the best therapy. Sodium bicarb is, it's highly debatable. It's kind of controversial in treatment because there's not a lot of pre-hospital large-scale RCTs to show any efficacy of the administration of sodium bicarb. Albuterol is given, often in the hospital to help shift the potassium intracellular because that's where it wants to be. The problem here is that we have a high serum potassium level, and what that causes is, issues with the cardiac conduction due to the membrane action potential of the myocyte. Not to get too nerdy, but when you have a high level of a certain electrolyte out of place, basically, it makes the other electrolytes less effective. So you're actually slowing down different phases of the action potential or depolarization of the cells, right? Which can cause them to go into lethal dysrhythmias. So one of that, albuterol might be a treatment to shift the potassium back intracellular. Also, insulin and dextrose is done, but of course, calcium helps to the balance out basically because it's a concentration gradient. So if you increase the amount of serum calcium, then you're going to decrease the amount of serum potassium in effect, or the effects of that high potassium in the blood. So that's what can be done. Eventually, they would need dialysis, and this patient did not get that and went into cardiac arrest. So what we do know, what most people know when it comes to high potassium levels, is that it cause peaked T waves on a 12 EKG, but that's usually elevated potassium levels, but not as severe as what you see with a sine wave. So I'll kind of talk to you a little bit about the evolution of hyperkalemia on an EKG. You will get peaked T waves when you get potassium levels over 5. So, 5, let's say 5.2 is the threshold. So when we say we have potassium levels in the 6s and 8s, that's a pretty high potassium level. So when you get over a potassium level of, 5.5, you start to have those peaked T waves. And then you'll actually get a widened QRS and loss of P wave, and then eventually the sine wave pattern. Here's kind of the gradient or the evolution of these changes. So, you get a potassium level over 5, and you might see something like a peaked T wave, right? The T wave gets taller, and it'll look kind of sharp on top usually, in contrast to like a hyperacute T wave that you might see with an MI that has a wider base. As you start to have potassium levels elevated over 6, like 6.5, you'll start to see a loss of the P wave, and then eventually a widening of the QRS complex as you start to approach 7 and get in excess of 7 millimoles per liter. And then once you have serum potassium levels in the range of 8 and above, a sine wave and then eventually ventricular fibrillation are likely. So these patients require emergent treatment. It's difficult to identify without getting, of course, solid history. Remember, every 12 EKG comes with a patient, and this, of course, EKG fits that patient's history and the condition that they were in. And that, of course, is this EKG case. I hope you enjoyed it. Thank you very much.